And welcome to the Dr. Bob Show. There are two arteries in the neck called the carotid arteries. If those get sick, then we could have a stroke. If we have a stroke, it could leave us in the condition that we're all afraid of. So we're going to be talking this show about how to keep you from getting a stroke from carotid artery disease. My guest is Dr. Afshin Skibba. Dr. Skibba is a board-certified general surgeon, board-certified vascular surgeon, and has spent a great deal of time with one of the world's leading authorities in carotid artery revascularization. That's fixing the problem. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about AFib and why we need anticoagulants. And the next time you see your doctor, are you going to see your doctor or your cell phone? Might be surprised. A lot of information for you. I hope you see your doctor. We're talking with Dr. Afshin Skibba, board-certified general surgeon, board-certified vascular surgeon, and has spent a great deal of time under one of the world's leading authority of a TCAR. And we're going to be talking about a TCAR in this show. It's a way that may save your life and mine. Welcome to the Dr. Bob Show.
Thank you for having me.
And so, Afshin, tell me, what is a TCAR procedure?
Well, it's one of the new carotid procedures that's used to open up narrowing in the carotid artery for people that are at risk of stroke or have recently had a stroke and need to have that risk reduced of having a future stroke.
So is this the coronary artery or is this the carotid artery?
It's the carotid artery. So we've got two carotid arteries here in the neck, and there are actually two other blood vessels that give blood to our brain, smaller ones in the back called the vertebral arteries, but the two carotid arteries, those are the workhorse arteries. They deliver most of the blood to the brain.
Where do they come from?
They come off of this big blood vessel in the chest called the aorta, and that actually gives blood to the entire body. And so there's a lot of blood going through those blood vessels.
So they're the path of least resistance that goes up to the brain.
You got it.
Now, what can happen to those carotid arteries?
So in a lot of people, in the neck, those arteries can develop an area of tight narrowing. And if that happens, they're at risk of stroke. Basically, a tiny piece of plaque or a little blood clot can form just beyond that area of narrowing. And when that travels up to the brain, that blocks one of the blood vessels in the brain, and that's a stroke.
And sometimes we call that a brain attack, which is similar. Now, what causes that carotid artery to be diseased?
Well, there's a lot of things. Diabetes, smoking is the number one thing that's indicted.
Smoking. We blame everything on smoking, and it causes everything.
It's the truth, though. Smoking is number one. Diabetes, trouble with cholesterol control, high blood pressure, they all play a role, but by far and away the most common cause is smoking. I should say, though, that
they cause what disease in the neck, though?
It causes something called atherosclerosis, which is hardening of the arteries, and it causes this narrowing trouble, not just in the carotid arteries, but elsewhere in the body too.
So can it be fixed?
It can be fixed, and thankfully, most of the time, it's something that's a straightforward fix.
Straightforward fix. So it's done frequently?
Yes.
The treatment of carotid artery narrowing, we call it carotid artery stenosis.
Yep.
How do you diagnose it?
Well, a number of ways. So, number one, when you go to see your primary care provider, oftentimes they'll put their stethoscope on your neck and listen for a certain noise called a bruit. Yep.
Is that pretty good?
That's pretty good, yes. That's a good rendition. So yeah, they'll hear that bruit. That's number one. Number two, a nice diagnosis comes from something called an ultrasound, where they use this machine that they just put it on your skin. It uses sound waves to look inside of our body. That can tell us if the carotid artery is narrowed. And last but not least, if it looks like someone has this carotid stenosis, the narrowing of the carotid artery, we do something called a CT scan that gets very detailed, basically X-ray images of those blood vessels and tells us if the trouble is something that is sufficiently bad where they're at risk, and number two, if we can fix it.
So when you do a CT scan of the carotid artery in the neck, what's it look like if it's bad?
Well, you see a normal blood vessel that then tightens down to a really tight channel and goes back to normal again. And
So you know that's where the problem is.
correct.
And that's where you hear the my
Exactly, yes.
rendition of that.
That's exactly where that sound comes from, yeah.
Of that bruit. So what is the problem when you get narrowing there? What can that do to the brain?
Yeah, so in some circumstances, a little piece of plaque can break off of that area of narrowing, or what happens is that there is a relative area of low pressure just beyond that area of narrowing. If
Yeah.
you imagine kind of a dam in the water, just beyond the dam, you might see these swirls, and same sort of thing happens with blood, but the problem with blood, unlike water, when blood doesn't move or moves very slowly, it forms clots. And so just beyond these areas of narrowing, a little clot can form, and when that breaks loose, that can cause the stroke.
Big trouble.
Big trouble.
What are some of the symptoms if somebody gets a stroke?
So on the side that's affected, they'll get something called amaurosis, which is blindness of that eye, where it's like a black shade coming down over the eye.
Because the carotid artery eventually supplies the blood to the eye.
Exactly, yeah. The first blood vessel that comes off of that internal carotid artery goes directly to the eye. And so temporary blindness in that eye is a sign that that carotid artery is causing trouble. The other thing that can be caused is on the other side of the body, the arm or the leg or both can become weak or numb. And the reason for that is the way that we're all born. Our wires are crossed in the back of our neck in the brainstem. And so the right side of our brain controls the left side of our body and the same vice versa. And so if that half of the brain gets angry because there's a blood clot or a plaque that's gone up in there, that affects the function of the other side of our body.
So those are warning signs. When you have those symptoms, what are you supposed to do?
Immediately go to the emergency room.
And 911, get the emergency room, maybe take an aspirin, maybe not, but they can tell if it's an explosion stroke or a narrowing stroke. So the treatment that we have for somebody that's got obstructed, blocked carotid artery in the neck, is there medical treatment?
So to start off, if it is just a mild to moderate narrowing, then absolutely medical treatment is extremely important. Usually that entails at least one, what they call antiplatelet medicine. The most common is just a baby aspirin, just 81 milligram aspirin. A lot of people take it. Second thing is a cholesterol medication within the family called statins. Those are the Lipitors, Crestors, those kind of medications. And what they found is completely independent of their cholesterol lowering qualities, these statin medications also stabilize plaques in blood vessels to the point now where certain procedures that we do on the carotid artery, it would be a divergence from the standard of care to do it without them being on these cholesterol medications. So the combination of being on a platelet medicine and one of those cholesterol medications is really important, whether they need surgery for the carotid or not.
So how do you make a decision if somebody's got mild or moderate carotid artery stenosis? Mild or moderate to me says, hey, fix it, I'm scared.
Sure. So the way that decision is made, it's all based off of national guidelines, but essentially the more narrow the carotid is, the higher that someone is at risk of having a stroke. And the easiest way that I describe this to my patients is I say once the risk of stroke, if we do nothing, exceeds the risk of stroke of the procedure, then it's time to do surgery.
So there are surgical procedures if the medical doesn't work or if there's so much narrowing. You haven't got time for medical stuff, we need to get to work. So is the surgical stuff effective?
The surgical stuff is effective, and I should also mention that those medical treatments that we talked about a moment ago, those minimize the risk of progression. They don't really undo what has already occurred. So if someone has been smoking for a long time or they've had cholesterol problems and they develop a carotid stenosis, this narrowing in the carotid artery, those medications will kind of slow down the progression, but they don't reverse it.
And so you've got to frequently evaluate that stenosis with an ultrasound to see if it's getting worse, and if it's getting worse, it may be an indication for surgery?
You got it, that's exactly right.
And that's what we're going to be talking about when we come back. Surgery, you got it right. We're going to end up talking about a TCAR procedure. I want you to understand this is the newest and perhaps the bestest, and you heard it on the Dr. Bob Show. You're going to want to stay tuned. We're talking with Dr. Afshin Skibba, board-certified general surgeon, board-certified vascular blood vessel surgeon, who has spent excessive time with the world's leading authority in a special new procedure that may save your life and my life. So, review. Carotid arteries in the neck, they get narrowed by hardening of the arteries. There's medical treatment. Medical treatment includes something to keep clotting from occurring, aspirin, one baby aspirin a day, and some anticoagulant, blood thinner medicine. And now we're talking about surgery. So I just found your teaching just fascinating, but tell me about the historical parts of correcting carotid artery stenosis.
Yes. So once the narrowing is sufficiently severe that someone is at risk of stroke despite receiving maximal medical management using the medications you mentioned, then they need something to mechanically open up that area of narrowing to reduce the risk of stroke. So the first procedure that was performed is something called a carotid endarterectomy.
Carotid endarterectomy.
Correct.
That means what do you do?
So we open the neck, we open the artery, remove all the plaque and blockage trouble, and then repair the artery with a patch. And this has stood the test of time and is still an excellent operation that is performed frequently today still.
So you have to go in the neck and you have to,
Yep.
you have to cut out that hardening of the artery plaque.
Yep.
And when that happens, some of that plaque you said earlier could go to the brain.
Yeah, so the risk of stroke with that procedure, depending on which risk category the patient is in, is somewhere around 2-3% if they are not having symptoms. If they are having mini strokes, then it could be upwards of 4 or even 5%.
You know, a lot of patients say, you know, statistics are statistics, but when it's me, statistics don't matter because
Absolutely.
it's my life we're talking about.
Yeah.
So let's go on from the endarterectomy to
transfemoral stenting. So there's a
transfemoral. So femoral means down in the groin.
Yep, artery in the groin.
Uh-huh.
And so new technology came in where we have wires and these things called stents, which is basically for lack of a better term, a small metal pipe that you can expand to open up that blockage trouble.
I call it a slinky.
A slinky, yeah, it looks a lot like a tiny slinky actually, yeah. Or Chinese finger trap is something I often tell my patients, looks a lot like. So when you go through the artery of the groin or the arm, that type of stent can be delivered in the artery, opening up that blockage trouble with just a poke hole. And it's a very nice piece of technology that we use elsewhere in the body frequently, but one of the drawbacks is that when that balloon and stent is used to open up that area of narrowing, a certain amount of debris gets liberated. It's kind of like sand almost. And in the carotid artery, when that happens, that debris goes north into the brain and basically can
that's the way the blood's going.
Can cause a stroke. And so what they found is because a lot of older folks who have this carotid artery narrowing, they also have what's called a tortuous aorta, which means their aorta has a little bit more of a curve to it than younger folks. It wasn't clear if the stroke that was occurring from these stenting procedures was by way of coming through that aorta and navigating that tortuosity, if something flaked off of the aorta as a consequence of that. Was it because these little baskets that were manufactured to try to catch that debris? Initially, to get that into place, you had to cross the narrowing unprotected to get that basket into place. Is that what caused the stroke? Or is it when you capture that basket at the end of the procedure that some debris comes loose? Is that what causes stroke? Long story short, that stent procedure had a substantially higher risk of stroke than the surgical procedure, the endarterectomy. So by and large, it was done very infrequently for that reason.
So that's going to lead to the new TCAR, transcarotid artery revascularization. Get that blood. How do you do that?
So it's an amazing marriage between those first two procedures. It's a little incision right above the collarbone here.
Okay, that's right here.
Right here, yep.
How big is a little incision?
2 inches or so, two
Something
and a
like
half
that.
inches. Yeah.
Leave a big old nasty scar?
Usually not, because right on top of the clavicle there, on top of your collarbone, once that heals, the scar is basically invisible because it's parallel to the bone.
Yeah, the ones that I've seen there, you don't know they're there.
Exactly. So you make a little incision there. We expose that carotid artery there in the neck. We put a sheath into the artery, which is just a tube basically, to gain access to the artery, and do the same thing with the vein in the groin called the femoral vein.
So femoral vein. Now the veins are carrying blood to the heart. The
Correct.
arteries are throwing it out to the body.
Correct.
Okay, so you got femoral vein.
Right.
What do you do with it?
We connect the two with just a simple tube. There's no fancy pump or anything like that. It's a tube that has a filter in it. And blood, just like any fluid, it takes the path of least resistance. It goes from the high pressure artery down to the low pressure vein. And by doing so, it actually reverses the blood flow in the carotid artery temporarily while those two are connected with that tubing.
Wow, so you've got blood flow that changes away from the brain.
Correct.
Down to the foot.
That's exactly right.
Down that way. And now, how long does that take? Your brain can't spin, the brain has to have blood.
Well, the brain has to have blood, but usually that's taken for about anywhere from 8 to 10 minutes is typical, sometimes longer, sometimes shorter. But as it turns out, that is extremely well tolerated, and it's not really understood why just yet. But this TCAR procedure has a lower risk of stroke, not only compared to the previous stenting procedure, but also compared to the endarterectomy procedure. And
so it's a win-win situation.
It's a win-win situation.
You've got a new procedure.
Yep.
How much training? Tell me about the training you had in this procedure.
So I did a number of them in Memphis in fellowship before I came here to Knoxville, and I've done a multitude of them here in Knoxville as well. I've got my whole team trained to do them.
Oh my goodness.
My partners at Premier Surgical, and actually last fall we received an award, a Center of Excellence Award at Fort Sanders, where I do most of my open surgeries, being a TCAR Center of Excellence.
Doesn't that make you feel proud that when when you've got that title like that? What was the doctor's name down in Memphis?
Dr. Ed Garrett.
How many of these procedures has he probably done?
Gosh.
Whole bucket.
Yeah, a whole bucket.
Over 1,000?
Yeah, oh yeah, I'm sure.
Okay. And so you've done more in this area than anybody else, and Fort Sanders has the Center of Excellence for the TCAR procedure.
For the whole region. Yeah.
For the whole region.
Yeah, the only three in our region are Dr. Garrett's program in Memphis, one of the surgeons, vascular surgeons in Jackson, Mississippi, and our team at Fort Sanders in downtown Knoxville.
That should even make you feel even, I think that's exciting, but it really is exciting because you've got a procedure that can help people in a way that nobody else can.
That's exactly right. It has the lowest risk of stroke of all three procedures, and it's taken all those other issues that had come up in the past off the table. You don't have to do anything with the aorta, the big pipe in the chest. You don't need any basket or anything like that. And so when that blood flow is reversed, it's just a simple reversing the blood flow, opening up the blockage trouble, removing the system, and it's all very clean and straightforward.
To me, that's amazing. So what you've done is, while you're doing the procedure, nothing can go up to the brain, or essentially nothing can, and it goes away from that until you open it back up?
Yes, that's yeah. So at the end of the procedure, we remove the tube and the filter, so blood goes back up the natural way to the brain at that point.
So what does the patient notice, and what's the recovery time, and how gratifying is this?
Well, as the surgeon, I find it very gratifying. In terms of what the patient feels, usually what I tell my patients is that they won't notice any difference because the whole purpose of the procedure is stroke risk reduction. So you don't actually feel any better as a consequence of the procedure. All it does is it takes a high risk of stroke and it drops it down to a low risk of stroke. In terms of recovery, for most people, they get back to their regular daily life the very next day. Wow. They spend one night in the hospital, they go home the following day, the vast majority. And
Dr. Afshin, Skibba, we're out of time.
Okay.
I don't know that I've ever seen a better teacher than you are in this procedure. And here you are, the only one in this region. Thank you for coming to the Dr. Bob Show. Thank you for keeping us up to date. And you heard this first on the Dr. Bob Show from Dr. Afshin Skibba. vascular surgeon doing, wow, TCAR.
Yep.
Thanks again for coming.
Thank you for having me.
What a great show. Tape it, retape it, tell your friends. You're going to have that carotid artery taken care of. Do it the right way. And now you're going to want to stay tuned. We're going to be talking about, next time you see a doctor, are you going to see the doctor or are you going to see your cell phone? You might be surprised. And AFib, why do you need anticoagulants? I want to thank Dr. Afshin Skibba. Wonderful discussion on TCAR. If you've got neck bruise, if you've got hardening of the arteries or the carotid arteries, think about what kind of treatment is best for you. Now, questions from you, the viewers, that I think will be important to your health. Dr. Bob, first question, why are anticoagulants, blood thinners, needed in AFib? AFib, atrial fibrillation, is the most common chronic irregular rhythm in medicine. The heart is beating irregular, and 25% of strokes is because a certain part of the heart, the left atrium, a little dog ear area in the left atrium, the blood is stagnant, forms a clot. The clot then goes into the big pump, goes up into the brain. 25% of strokes are due to atrial fibrillation. So why do we need a blood thinner? So you won't get a blood clot in the left atrium that goes up to the brain. It prevents that stroke. How long do you need to be on them? You know, that's dangerous because blood thinners can cause problems if you get in an automobile accident or somebody hits you in the abdomen or you get cut. It may be difficult to stop the bleeding that way. So there's a risk and a benefit. So right now, I don't think we really know how long that we need to be on blood thinners after somebody is diagnosed as having atrial fib. So that's something you and your doctor need to work out and know that you might be on a blood thinner for a long, long time. Question number 2, Dr. Bob. Is Apple trying to, or artificial intelligence, trying to take over medicine? It's an interesting question because there's no way that artificial intelligence, Watson, is going to do a better job than the doctor can. There's nothing like the doctor to say, here, let me see what your problem is, I want to help you. But let's look at some things that we've got here. Number 1, let's just look at your cell phone. The next time you go see a doctor, it may be in your cell phone. You got telemedicine, he can see you and you can see him and he can talk to you. But that cell phone also, if you're putting it in your pocket, can really tell you what your pulse is. If you wear it at nighttime, it can tell you how you're sleeping at nighttime. There are apps there that will track your sleep, will tell you if you're snoring or not snoring, and they'll actually be able to tell you if you have obstructive sleep apnea. There are apps and there are artificial intelligence like this blood pressure cuff. This blood pressure cuff, when I push a button on here to start, it will begin to program itself and it will tell me what my blood pressure is, what the numbers are. It will tell me what my pulse is, and it can send that information up to the sky. In the United States, if there are 10,000 of these done every hour or every day, then they'll all go up to artificial intelligence, and artificial intelligence will be able to know what your age is, what your ethnicity is, what your blood pressure is, what the difference is in those two numbers, and when it measures it from 100,000 patients, it may be able to give the answer on what your problem is, what kind of blood pressure you have, what medicines are best for you, so they will help your doctor, or it may roll out a prescription that you take to your drugstore with artificial intelligence. So know that the cell phone has lots and lots of information. I've got an app on there that tells me how far I've walked that day. They'll tell me how many calories I've had. They tell me how my sleep pattern is. They'll tell me where I'm going. When I get in my car, it says, you got 13 minutes to get home. And I'm saying, how in the world did they know where I was going? Well, they know. And that artificial intelligence will make medicine better and eventually get to the point where, who knows, this may be your doctor on the next visit. Getting closer and closer to that. All the time that we have for this show, hope you've enjoyed it as much as I have. It's been really fun for me to talk to Dr. Skibba. And now, 4 things: exercise reduces stress, makes you feel better, gives you a runner's high, helps you lose weight, relaxes you, takes away anxiety. Eat properly, eat foods that are full of vegetables, fruits, and fibers, and not fatty, greasy foods. Eat less food. Make your breakfast and your lunch more than the afternoon meal. 7.5 hours, 7.5 hours sleep. Be sure that you're getting enough sleep. If you get enough sleep, it'll make you feel better. You'll do better. You'll perform better. The people around you will perform better. And so there's nothing like 7.5 hours sleep. We're learning more and more about sleep and your health. It may end up being as important as exercise. And most of all, what is it that we like in that Dr. Bob Show? It's that laughter in your life. Are you laughing enough? Because when you laugh, you'll be happy. The people around you will be happy. Your immune system will work better. Your life will be better. You'll be rested, and you will be healthier.